mode yet, but there you go. Perfect. Looks great.
All right. It seems like there's a little delay. So if for some reason that happens again, feel free just to unmute and let me know. So again, I really appreciate the opportunity to join you all virtually. It's a little hot and humid in North Carolina. So I don't know, you all probably have a little bit better weather in the Midwest, kind of know that firsthand from being in Michigan for a while. But as the introduction stated, I am at Wake Forest. So I don't have an introductory slide kind of describing my journey, but I've been very fortunate to work with folks in aging at Michigan, at UCLA, both on the academic side and on the VA side, and then spent my first few years on faculty at Duke, and then really wasn't looking to make a move. I had a K award that was up, and it just so happened that Wake Forest was starting what we have as the first and only academic department of implementation science in the entire country. And really just having had some folks or collaborations at Wake Forest, specifically at the Pepper Center, it was an opportunity that I just couldn't turn down. And so here I am. So we always get a little bit rushed at the end. So just wanted to take a minute at the beginning to actually thank all of the folks that make this work possible. So I have the great pleasure and honor of leading a research team that we refer to ourselves as the Amaze research team. So Wake Forest merged with Atrium Health, I guess, about 18 months ago. And then there was another merger with Advocate Health, which is prevalent throughout the Midwest. And so we are the Atrium Health Wake Forest Baptist Movement and Z's for Everyone. And I have a number of folks to thank, past and present, from my day-to-day research staff, mentors, collaborators, and also current funders are listed here. So my love and kind of focus in my work is really sleep, and sleep in how that impacts older adults. So at the same time, although that's my kind of first love, I will say I kind of hate when folks kind of pigeonhole me and say, oh, she's just a sleep researcher. So no, really, I'm an aging researcher, and really my goal is part of my work. So I didn't say my formal training is a mixture of public health or health behavior, geriatric social work, and then health services and implementation science, both on the kind of postdoctoral and K level levels of training. So my goal really is to optimize functional independence so our older patients can age in place. For most of them, that means aging in their home. So I think for many of us, if I were to ask for a show of hands, when we think about how do we optimize functional independence, our minds typically go to activities. These are often kind of our more physical activities, exercise-based, kind of resistance training, strength training, balance, aerobic activity, maybe a mixture of kind of leisure time, golf, tennis, kind of recreational sports. Walking the dog is certainly activity, but they can also include kind of, again, those more leisure kind of pleasant events. What we don't think about is activity kind of happens during the day. What's the flip of activity? And that's inactivity or sleep. So about 2/3 of older adults actually complain of sleep problems. And I started my career, I did things kind of all out of order. I started my career in the VA, in the GRECC in Ann Arbor, was freezing. I was born in Michigan, so very cold in the Michigan winters, or excuse me, I was born in Arizona, very cold in the Michigan winters. And from there, headed out to the Los Angeles VA and UCLA and the GRECC there. And that's really where my kind of love of sleep research really started almost 12 years ago. So I did a lot of work. Veterans, by their very nature, tend to be very complex. I actually gravitate towards the really complex patients. If you're healthy, if you're fine, you know, let someone else kind of take care of you. If there are problems to solve, you know, please come to me. I'm really interested in kind of helping those more complex patients. We also did a lot of work in the adult day healthcare center. So this was a VA rehab facility. And these were older adults with, gosh, a dozen or more chronic conditions, maybe 24 or more medications, competing cognitive and functional limitations. They were still living at home in the community, but essentially one fall or illness away from moving into some sort of residential facility or residential care. So a big kind of piece of the adult day healthcare program, or what I'll refer to as ADHC, was this group and individual-based activity. What we noticed in working with this population is when we asked them, I would love to sort of I would ask them, can I ask you about your sleep? Sure. How are you sleeping? Oh, I'm sleeping fine. I don't have any problems. I was like, well, that's really interesting. I wouldn't necessarily say this. You either patients were calling in all the time and saying, I'm not coming today because I didn't sleep well the night before, or better or worse, however you want to kind of phrase it, they would come and then they would essentially refuse to engage in any sort of group or individual activity, whether it was a game, a cognitive activity, but more importantly, that physical activity. And when they were describing their sleep, they would not describe kind of these more traditional nighttime symptoms, having trouble falling or staying asleep, but they would talk more about daytime consequences of poor sleep. I feel tired, I'm less motivated, I don't have enthusiasm. Maybe my family or spouse or partner or someone around me is complaining of that same thing. I'm having trouble concentrating, I'm moody, I'm tired. Or again, kind of what I alluded to, my favorite is when these folks would come to the ADHD, they would make it, and then they would essentially just sleep throughout the day. So again, rehab was really important. That activity component of the rehab setting was really key to keeping these folks, again, functionally independent so that they could stay in their homes. So what we saw is less physical activity in this complex patient, which, as you might guess, led to more increased sedentary time. Well, the more that these folks were sort of sitting around, not engaged physically, emotionally, socially, they would nap. Well, our bodies only need one chunk of sleep throughout the day. So anytime any one of us, especially as we get older, nap either in the daytime and evening, that makes it harder to sleep at night. Well, if you're not sleeping at night and you don't feel well during the day, again, we kind of start this cycle anew, and it's this vicious cycle of thinking about sleep more. Really, this was kind of my first realization and aha moment is, are we thinking about sleep really almost incorrectly? It's not a nighttime phenomenon. It's not sleep and activity. It's activity and inactivity, or day and night. So I won't talk in detail, I know, and we just heard a little bit as folks were gathering. You all have a great amount of expertise in sleep research and circadian rhythms research happening there at Northwestern. But just as an overview, sleep naturally changes over the life course. Sleep starts changing in our 40s. So I hate to break it, I can say I'm in that decade. I experience it firsthand. And as we get older, we spend less time in deep sleep. Towards later decades, there's a shift in our circadian clocks where we all naturally want to go to bed earlier and get up a little bit earlier. So again, kind of normative changes in sleep over the life course. What's not a normal part of aging is sleep problems. So I alluded to this a few slides ago, but approximately 2/3 of older adults complain of sleep problems, insomnia specifically. And let me just put out a disclaimer. I'm a behavioral interventionist. I have a background as a behavioral scientist in behavioral medicine. I focus mostly on insomnia. I will not talk a lot about sleep apnea. If there are particular questions, we can certainly address them at the end. But clinical criteria of insomnia includes difficulty falling or staying asleep, or waking up earlier than desired. And those kind of symptoms occurring 3 or more times per week for 3 or more months or longer, importantly with a negative impact or daytime consequence resulting from that poor nighttime sleep. I could spend probably a good quarter of this presentation just reviewing some of these kind of consequences of chronic insomnia or chronic sleep problems: reduced cognitive and functional performance, worse quality of life. And most importantly, we know that there's a strong body of epidemiological and longitudinal data that suggests poor sleep and chronic sleep problems really accelerate negative trajectories of aging. I see a hand. I would prefer to take questions at the end unless there's some sort of technical difficulty. So as I kind of suggested, insomnia is actually a behavioral disorder. So this model in front of you is known as the 3P model of insomnia, developed really in the late 80s, early 90s. And the idea is we all, no matter our health status, no matter our age, have some predisposing or genetic kind of risk factors. So these are the green bars at the bottom. We also, again, all of us, no matter our age, no matter our health status, no matter where we live or who we are, have life and stressful events. This could be as simple as, on one night you have a really early flight, you can't sleep. We have, the pandemic certainly was stressful for many of us working in the field that we do. A health change, anytime we're sick, anytime we have a cold. What happens with individuals who have insomnia is, and again, this can be any one of us, we kind of enact these behaviors to try and make up for poor sleep. We're tired, we drink more coffee during the day. Maybe we can't sleep at night, so think, oh, a little bit of a nightcap is a good idea. I'm up in the middle of the night, let me just watch TV for a little bit in the bed, in the bedroom, that will make me sleepy. I didn't sleep well last night, I'm so tired, so I'm gonna go to bed early the next night. It's these behaviors that are not usually healthy, they're typically unhealthy or unhelpful, that really kind of perpetuate insomnia. So these are, again, kind of the yellow boxes, or these stressful life or health events. We try and kind of compensate for this poor sleep with different types of behaviors. And these behaviors over time often continue. And this is really kind of a true perfect example of kind of classical conditioning. We can't sleep, our minds and bodies are confused, or what are we supposed to do in the bed? Is it sleep? Is it be stressed? Is it be awake? Is it watch TV? And over time, really, these behaviors are really kind of what sets us over and keeps any one of us over kind of that threshold and makes insomnia chronic. These behaviors are actually also what's at the root. These are all modifiable behaviors for the most part. And that's really what's at the root for behavioral treatments. So cognitive behavioral therapy for insomnia is the gold standard, first line recommended treatment. This comes from NIH, from the American Academy of Family Physicians, from a number of different governing bodies in terms of medicine and research. However, there's a big challenge. So this data is a little bit dated right now, but still, I would say probably not a significant improvement. Is there are about 200 certified behavioral sleep medicine specialists nationwide. Here in North Carolina, where I currently am, there are fewer than 20. As of last check, there was only one within the Wake Forest healthcare system, and that was someone who was actually at our children's hospital. So this data could be from North Carolina, some kind of East Coast, New York, California, West Coast, kind of the East and West Coast major states tend to be a little bit better on the statistics, but in part, very few providers to deliver cognitive behavioral therapy for insomnia, or CBTI, across the nation. So this was particularly true, again, kind of about 10, 12 years ago when I was first starting in geriatric sleep medicine out at the Los Angeles VA at the GRECC. So what we did is we adapted CBTI specifically for older adults. And the studies that I'll focus on today, or that really continue to fuel my work, are again the study that we adapted for the Adult Day Healthcare Center, or ADHC. So Sleep Well, or Swell, is a 4-session intervention that includes 4 core components. So 1, sleep compression. Typically, when folks have insomnia, they spend, for example, say 8 hours in bed, and they're only sleeping 6 of those hours. So typically for a healthy, kind of younger or middle-aged adult, we would do sleep restriction. We'd say if you're only sleeping 8 hours, or if you're only sleeping 6 hours of those 8 hours, you only get to spend 6 hours in bed. Patients get worse, they feel horrible. You give them your office phone number and say, feel free to call me and complain in the middle of the night. And every now and then, some patients do. The key is doing that, they get better, although it's kind of hard work at first. That's a little bit riskier for some of our frail patients. So what we do is actually we compress sleep 15 to 30 minutes at a time, week by week, and kind of titrate them over the course of the treatment program. Stimulus control, a lot of folks who can't sleep, and I have heard it all. I had a patient who made coffee from his bed, also had a microwave kind of right out of reach of his bed, did everything, paid bills, watched TV. He couldn't sleep. So what happens, like I mentioned, the brain and the body get really confused. Am I sleeping? Am I awake? Am I eating? Am I stressing over bills? Am I on the phone with a friend? So the idea is the bed is only for sleep, sleep only in the bed, move those activities out of the bedroom. For a lot of our older adult patients, and I don't think this is news to this group, they don't necessarily have major routines. They might be retired. We certainly saw kind of routines and interaction and engagement really disappear during the pandemic. And unfortunately, that's still true for a lot of our patients. So the idea of routines in what we do and who we see and the light we get and when we eat can also help regulate our sleep. And again, this was a really kind of frail population, a high risk, not even rising risk, a high risk population. So we talked a lot about, well, what can you do if you have a change in your health status, if you have a stressful life event? What strategies can you enact to help prevent a relapse of insomnia? So 4 sessions, about 20 to 30 minutes tops, and actually delivered by our whole goal was for these sessions to really be delivered by a sleep naive provider. So a master's level health educator or a master's level social worker who was coached by a clinical psychologist for any kind of clinical questions, but ideally someone who had never done CBTI before in their prior training or their prior work. So in our clinical trial, we actually saw improvement both in nighttime sleep and daytime function. So here we have wrist actigraphy. So these were the good old days with our high-end, very reliable Philips Respironic actigraph. But we saw these individuals have fewer nighttime awakenings and less time awake during the night. There was also an increase in sleep efficiency, which is kind of the gold standard metric, which is a percentage of the total time asleep out of the total time in bed. On the patient-reported side, really interesting, we didn't necessarily see kind of patient-reported improvements in these nighttime metrics, but we did see improvements. The patients reported feeling less fatigue and having less daytime function resulting from poor sleep. So again, kind of thinking back to that initial kind of slide with the day and night, this we thought was really significant because again, these were patients, or kind of clinically significant. These were patients who are not coming to engage in the rehab activities because they, quote, felt too tired. So these were all promising findings. So this was VA, you know, more so now, but always, you're not funded in the VA unless you promise to then take what you know or what you find to be effective and translate that back into practice. And so what I'm doing today is I won't talk about any VA work today. I still spend about 1/3 of my time actually with the Durham VA. But how do we, when we find this program that we know to be effective, Swell or Sleep Well, again, years and decades of research to show that CBTI is effective, Swell adapted for older adults is effective. How do we get this into practice? And what I'm hoping to use the rest of the time is really kind of an overview of my research program. So again, I did things a little out of order. So I'm very, very fortunate that I had excellent mentors even before I was at the Los Angeles GRECC before my doctoral program. So this really kind of reflects a body of research that I've been working on for 10, 12 plus years, but kind of hoping to showcase how can we move kind of one particular condition, insomnia, or programs to help those conditions, how can we move those things forward? So I really see a few different kind of critical steps to getting Swell out there in the world. One is simply kind of scaling and spreading. We know that Swell works. And I showed you one of our team's clinical trials or RCTs. There are multiple that I could have given you examples of our evidence. We also kind of started to, you learn as you go. How can we make Swell even more effective? Can we make it even better? Is there something that we can improve? Can we optimize our existing program? And then again, kind of clinical practice is always changing, and certainly there are many good and bad lessons to learn from the ongoing pandemic. So how can we think about developing novel tools for sleep assessment and intervention? But really the first kind of part, or the first kind of heart of understanding and moving any of these steps forward, is really understanding the scope of the problem. So we are actually, and if folks were on as we were gathering, I was sharing, I just got more than 100 postal surveys. Yes, believe it or not, we still use postal mail, and we find it to be very, very, very effective for older adults. They are happy to get something that is not a bill, and they are happy to get something that asks them about how they're doing and maybe potentially link them to help. So at the Los Angeles GRECC, again, kind of more than 12 years ago, we sent out this "How are you sleeping?" survey using data pulls from the electronic data warehouse to identify patients who had had one or more primary care visits, typically within this prior 6 to 12 months. So I'm actually replicating that here. We've used this across a number of veteran and non-veteran populations and find it to be very effective. So this is a self-reported questionnaire that we've validated against a number of gold standard screening tools. And the idea is, can we use a screening tool outside of a clinical encounter, outside of Epic or Cerner or whatever your system's EHR is, to start identifying patients with poor sleep? So I'll show you, and apologies if this is a little bit small on your screen, but this is actually direct screenshots from our survey. So we had actually about a 40 to 50% response rate in past uses of this survey. And as I was telling folks as we were gathering, it is so interesting to look at this data. In the kind of bottom right-hand corner, you'll notice some questions. How would you describe your sleep? Kind of these quality ratings. And how long have you had problems with your sleep? I cannot count the number of older adults, and we've done some research on this. I'm happy to share those references if you're interested. In our frailer, more complex older adults, there tends to be this wide discrepancy. So in insomnia patients, we typically see, oh my gosh, I'm sleeping so horribly. I can't sleep. I'm going to get sick and die. And then really their actigraph or their objective or overnight sleep study says, no, you're not really sleeping as bad as you think. We see the flip in these older patients. You might gather that from what I described earlier. They're rating their sleep as just fine, as good. They've had problems, many from 5 to 10 years or more. And then as you look across these different kind of components of the survey, which map onto insomnia diagnostic criteria, they actually have very significant sleep problems. So this is actually really building kind of a big cohort that we call the Amaze Sleep cohort here at Wake Forest. And this is, we use it as our recruitment pool for any number of studies. But what I failed to kind of say is the reason that we're doing this is insomnia tends to be overlooked. This metric is getting much better, but we've seen kind of that 2/3 of older adults complain or meet criteria of insomnia. It's typically 5 to maybe 20% have ever talked with a doctor. So unfortunately, I can't go to my informatics and analytics team and say, hey, can you please pull all these, ICD-9 codes and look at insomnia and give me everyone who with an insomnia diagnosis. Unfortunately, the diagnosis just kind of isn't there. So this is how we identify folks. So kind of the scale and spread. This is where we start. We have a program that works. We have a program that is tailored to older adults, to their cognitive and functional limitations, to competing comorbidities. How do we get it out in the world? So I have an NIA-funded R21 right now that is actually no clinical trial allowed, which means this is fully mixed methods data collection. This grant feels like such an incredible gift. We are out in currently 4, this will be 6 by the end of the project, internal medicine and family medicine or primary care clinics in our system, to ask both patients and providers and staff as well, how many of your patients have insomnia? What are you doing? How are you screening? How does sleep health relate or rank to something like activity, to medication adherence? What do you do when you have a patient who can't sleep? Where do you send them? What information do you need and want? Could you deliver CBTI in your clinic? If so, how, where, who would deliver it? Who would deliver it, and what does that mean for reimbursement and cost and whatnot? And the idea here is really we want to take a program that was built essentially in the VA and make sure that before we go and say, hey, you know what, primary care clinics, we've got this great program, we think it would work. Let us hear from you. What do you need and want, both patients and providers, and let us adapt and refine our intervention and our implementation approach to align with those needs and preferences. And then the ideas will all work together on the multi-site actual implementation trial. So again, we have something that works. Let's get it out there. The next thing is we have something that works, but can we make it better? Can we make it more effective? Again, I'm a behavioral interventionist, a behavioral scientist by training. Hopefully some of you are kind of saying, wait, this kind of collection of circles and pathways looks familiar. This is actually the NIA Stage Model. So the idea behind this model, I'm not going to go into it in detail, is that intervention development is iterative. It can be unidirectional, bidirectional, and kind of what's laid out here, again, I'm not going to go into it, is if you look just kind of for the dates. I hate putting these dates on the figure because I think, man, 2010 to kind of 2023, I'm a part of the 17-year lag of why this intervention is taking so long to get into practice. But if you have questions, I'm happy to come back to this figure of kind of, we haven't always gone in a linear route. We are kind of spreading and scaling our intervention at the same time that we are refining it and optimizing it. And to optimize the intervention, so again, kind of my big question is sleep not really this nighttime only behavior? Should we be thinking about sleep differently? Should we be thinking about it as sleep as inactivity and then activity during the day and this more 24-hour continuum? So I am very lucky and very fortunate when I came to Wake. Had some money and did some things with the Duke Pepper Center, had the great fortune of being awarded a GRECC Scholar project. And so kind of in the sort of ongoing development of how do we make Swell better? So this is just really, again, kind of, I won't go into the details. This is actually pulled from the multi-phase optimization strategy, which is Linda Collins, the NYU Optimization Initiative. And the idea is, again, kind of intervention development and optimization is not a linear process. But here we're thinking about how can we look at our sleep-wake conceptual model? How can we think about those daytime consequences? Again, that's what older adults that we're interested in are complaining about, not the nighttime insomnia symptoms. And then how can we use this information to kind of optimize our intervention? And so my Pepper Award is, you'll kind of notice a running theme. We had Swell PC, which stood for Swell Primary Care. This is Swell 24, kind of, again, thinking about how can we always improve our Swell intervention? So we've actually started with that survey, and we also have, this is also a mixed method study, and we're asking older adults, anyone who responds to the survey, but also who comes in for some basic functional testing, how do you define healthy sleep? How does your sleep impact your daytime activity? How do sleep and activity as health behaviors relate? How do you see them together? And more importantly, kind of what do you do to keep yourself active? My kind of long held belief is that maybe we need to think about activity differently. There is a role and there is a place for resistance training, balance training, kind of the more formal physical activity programs and regimens. But as we saw during COVID, our patients were home, they were isolated, they were bored, they were engaged. They were not engaged. So what was happening? They were falling asleep. They were starting that cycle. So how do we think about kind of daytime activities? So our goal really in Swell 24 is to optimize not only the content, but also the outcomes. So we have our kind of standard 4 session of our original Swell program as the nighttime component on the left. And this kind of yellow dashed, this is what we're trying to figure out. What are those key daytime activities? Maybe it's just being more active during the day, but is it also saying, you know what, there are actually healthy sedentary activities, socializing, games, reading, puzzles, kind of what is the balance, again, to keep folks engaged? So not necessarily increasing activity. Oh, I want you active for 30 more minutes a day or so many minutes across the week. But how can we essentially kind of lessen that sedentary time? And also really starting to think about, again, that original Swell ADHD study, our patients were saying, I feel better, I can do more. And it's like, well, that's great. But what does that mean in terms of what do we measure? So really kind of in terms of improving sleep, in the stack of surveys that I have for patients who say, I have my poor sleep really negatively impacts my day. What is it that they hope to get out of improving their sleep? And the final kind of piece, so kind of again, thinking about how do we optimize sleep and optimize our evidence-based programs for healthy aging, is actually how do we think about our tools to assess and treat sleep problems? So I led a team that almost a year ago was the winner of an inaugural Accelerator Innovation Incubator funded by our Center for Healthcare Innovation. And what we have done, I shouldn't say we, because this is a very talented tech and programmatic team at the CHI, the Center for Healthcare Innovation, and I kind of tell them what I need and want, and they magically build it. I make it sound so simple, but it's not. This work wouldn't be possible without them. We are actually basically just leveraging ecological momentary assessment, or EMA, and saying there is such a strong use for EMA, or kind of these repeated assessments in real time, in kind of real world settings for older adults, but these aren't in clinical settings. And so what we have done over the past 6 to 8 months is actually engage in quite a bit of co-design and user-centered design with patients, with providers, with healthcare system leaders, to kind of say, what are your greatest challenges? What are your pain points in caring for older adults? And for many of our physicians, they say, I don't know what's happening. I see my patient maybe once every 6 months, and I have this, kind of piecemeal report. I don't know. Are they living alone? Can they safely walk kind of outside their home? And really, I don't have time to kind of dig deep into this project, but the idea is, again, functional independence. What are modifiable predictors of functional independence? Activity, inactivity. Those things don't necessarily happen within a provider's office. They happen at home. What is the social context? Does someone have social support or someone so that they can safely exercise? Do they live where they can go outside and walk or get natural light? How does someone feel during the day? How does that change within days and across days? And how can we start to take this contextual, patient level and contextual information and essentially feed it back to providers, so providers can start delivering these kind of person-centered, personalized interventions? So really what Patina hopes to do is kind of capture a more complete picture. So these are actually screenshots from a test kind of set of questions in MyCap. So this isn't our formal actual program, but this is The idea is Patina is a comprehensive platform that will eventually include a smartphone-based application. I should say Patina stands for Patient Integrated Assessment. Later this fall, again, our talented tech team will try and integrate the Fitbit. We can talk about pros and cons of the Fitbit with the smartphone assessment. And then eventually, again, we're in the middle of this big merger when all of our individual systems become one system and we're all on the same Epic in spring or summer of next year, we will eventually integrate this information into Epic. And what we're doing right now is kind of asking providers, when might you kind of order or prescribe Patina, and how might you use this information to guide shared decision-making with a patient? And so these are just kind of some of the snapshots. We start with kind of a good old, the 4 M's and what matters most, to borrow from some of the kind of work being done by our geriatric colleagues and legends in the field. But also, where do you live? Do you have folks with you? Do you have access to programs? This impacts what a provider might suggest for a behavioral intervention. We also, again, I kind of alluded to this idea of maybe we're not screening correctly for insomnia in our older adult patients. So how can we get at these kind of elements of kind of daytime consequences, feeling fatigued, feeling tired, having less motivation? How do those change over the day? This is a prompt that patients get several times at random points throughout the day. And then how does mood and pain change as well? And then finally, everyone gets a bedtime assessment with the opportunity to sort of, actigraphy can be great. It's certainly great to have passive monitoring. But we know that actigraphy also has its limitations. And so we don't necessarily know, are folks engaging in healthy or unhealthy sedentary times? And certainly where are they with, and kind of how do these contextual variables and activity variables essentially impact behaviors across the course of a week? So that was a very, very quick kind of snapshot and overview, again, of kind of my program of research. I want to just leave you with, you all are also in a healthcare system and in an academic medical center. So where are there opportunities to kind of advance the science and delivery of sleep screening and treatment? I have this kind of as the first box of big data, knowing also, if you were listening a little earlier in the talk, we don't necessarily have great data in our EHR systems to easily kind of pull, who has insomnia, what are the kind of characteristics, clinical characteristics and predictors of those individuals. Remote monitoring, Fitbit isn't perfect, but it's something. And how can we get information and passive monitoring on our patients, and think about also using this information as kind of digital biomarkers and risk identification? For example, how might someone with early cognitive impairment or risk for more rapid cognitive decline, what might their sleep and activity look like in the months and years leading up to that? And then also, again, I'm very passionate as an implementation scientist about how can we improve clinical care? How can we improve our assessments, our training? How can we identify? We're really in that Swell PC project working a lot with this idea of our APPs, really kind of a great kind of type of provider to deliver CBTI, and thinking about how in a post-pandemic world, or in a system like ours where we have patients who are 2 or 3 hours away from our medical center, how do we deliver CBTI? And with that, I will put my email up. I'll take the screen down so we can open it up for questions. But again, thank you for the opportunity to share a little bit about my work. It certainly wouldn't be possible without many folks across the country. And welcome questions, and also welcome any emails or contact at a later point in time as well. So thank you.
That was great, Jaime. Thank you so much for presenting that and really covering a large expanse of the work that your team is doing. Love the acronyms across the board. That's fantastic.
Why can I say a career in the VA? I have to have acronyms.
Yeah, branding is always very, very important. So totally appreciate it. Can I open it up for any questions? You want to raise your hand or just turn on your screen and let's make this kind of informal, but really welcome from the audience any questions for you. I think you're covering a very important topic that our Pepper Center is also very cares deeply about, with issues around undetected sleep issues. So
Looks like there's a question in the chat right now too.
okay, great. So yeah, a question was, why not combine with other healthy behaviors such as nutrition and activity as combined interventions, especially activity?
Yeah, so hopefully I mean, great question. I have long been a fan, both research-wise and kind of behavioral-wise, of these multi-component interventions. Research-wise and statistically and analytically, a little bit trickier to kind of come up with a study design and an analytical design, but I think it's hopefully this question was answered a little bit of, the idea is this Swell 24. The first kind of step is we think and we know based on our prior work that we should start thinking about nighttime inactivity or sleep and daytime activity more as this 24-hour continuum. And so really our work right now, through talking with patients and providers and caregivers, what should those daytime activities look like? And more importantly, what should that intervention look like? Should it be sequential? Should someone improve their sleep and feel better during the day before they engage in activity? Or should it be a kind of simultaneous intervention, and where we have kind of each intervention session is, okay, you should be doing this, at night or in the evening to improve your sleep, but also engaging in these activities. And like I said, we're leaning more and more and leaning kind of towards OT, occupational therapy, and kind of these folks tend to be so great about thinking outside the box, and the kind of further away from maybe more traditional exercise physiology, kind of PT driven interventions. This also has an implementation component. I, as a kind of researcher and behavioral interventionist, was tired of sort of saying, okay, you know what, I can help treat your sleep, and let me send you over to this colleague who can help with your activity. Patients also don't do that. They drop out. So how can we start, is there greater uptake and greater adherence in addressing multiple behaviors at once? So great question. Thank you.
Looks like Dr. Wolf had to step out, but any other questions?
Sorry, as you may appreciate, we actually have a ongoing trial that is looking for undetected aspects of cognitive impairment and sleep disturbance and so forth. And that was one of our clinicians calling me directly to inquire about the use of our tools. So I had to step away when I saw it was a second call. But hey, thank you. Just a quick question I was going to ask in the final minutes is, and again, this is really the work done by one of our Pepper scholars, Minji Kim, in concert with Phyllis Z and her center, is really around the issue around how do you incorporate into clinical workflows routine, proactive, detection efforts to start to understanding sleep. And I think some of the things you hit on that I really appreciate are the fact that it's just like with any screening method, you need to really have a good sense of what you're going to do about it. And I think what we've been learning, Minji's been learning, is there is a lot of concerns with, and in fact, we've even seen this in some of the grant reviews, that when you refer to sleep as a potentially modifiable lifestyle factor or behavior, people don't feel it's modifiable. And I don't know if you have thoughts on that, but it's I think just in general, getting the message out and providing kind of turnkey recommendations for how do you guide clinicians as to what to do if you're starting to kind of case find more often.
Yeah, great questions, and thank you for bringing that up. I think just starting with the kind of how do we identify folks? How do we screen? One of my, in addition to kind of this love and passion for, functional independence, keeping folks at home, is this really desire to, can we, what is the kind of $1 million question to identify older adults with sleep problems? We know that something simple like how are you sleeping or describe your sleep just doesn't work for those we miss a lot of folks for those very reasons I talked about. They're thinking, oh, I sleep just fine, or really they've had problems for so many years or decades that they dismiss those problems. So thinking about, part of this goal, even with all these surveys, is, we have about 10 or 12 daytime consequences. Should we be asking something differently, and how should we ask it? Can this work also help to inform kind of measurement, development, and validation? I think in terms of clinical workflow, so this kind of Swell PC, this primary care project, I was ready to not have to put up a fight, but to have to work really hard to identify primary care clinics who were ready and willing and interested in engaging with us. We kind of hit our recruitment. We had our clinics really kind of, it's immediately. And in our initial kind of recruitment visits, it's been interesting. This grant, it takes a while to, get NIH grants. This grant, we had originally submitted it right at the start of the pandemic. And so I think, unfortunately, what a lot of our, and I don't know how many clinicians we have with us still on the call, but a lot of them are saying, my patients are still scared to go back to a senior center, to go back to exercise. They had nowhere to go, so they started, having a nightcap every night, and then that turned into maybe 2 drinks, and that hasn't kind of been reduced or relieved, even though the pandemic is over. And so all of that to say, kind of sleep is very much at top of mind for even our community-based, our non-kind of geriatrics clinics. And that's our goal, is really kind of, again, I really meant it, of sort of this grant feels like a gift, because we get to go in and have these conversations and not just say, fill out the survey, how are you screening, would you do this? But, what are your competing, concerns? What else is in your workflow? Could we have our Office of Population Health Management send a survey like this, and then send your clinic a list of patients, to talk to when they come in? We've had a lot of folks say, yeah, but I go to Epic and I print out this, I can give sleep hygiene recommendations. So I think, again, sleep very much at the top of mind. I think we've been pleasantly surprised, and folks think about it as modifiable. To the critics who don't think it's modifiable, this is a little hard. Let's say if you're submitting a response to reviewers in the grant, but it's just if you're in conversation, well, how do you feel when you sleep well? How do you feel when you don't sleep well? The good thing we have is, everyone hopefully sleeps at some point across, every 24-hour cycle. So it's something that we can kind of bring in personal experience to when we're having these conversations.
Great. Thank you so much for that. Yeah, I do basically underline everything you said. And I'm really great that you're championing all of this work. And again, kudos to you on getting the award. And persistence is the key. And God forbid, COVID has thrown so many wrenches into the plans of grant reviews. So I think that's a message for all of us. I think we're at time. So, and it's always to give even a minute back to people before you have to resume another Zoom. Again, Dr. Hughes, thank you so much. We really appreciated you joining us today, and I'm going to make some connections with our center, and also, if it's always the hopes that we can actually bring you out and have time to really delve deeper into what you're doing. We obviously really welcome that. So thank you, and happy Friday.
Thank you. Thanks to everyone for taking your lunch hour, and enjoy the rest of your afternoon. And thanks again for joining.
Great. Thank you. Take care.